Hello student, now we are going to start a new topic, that is renal physiology. The first thing that we are going to discuss is functional anatomy of the kidney. So all of you know that the structural and functional unit of kidney is nephron, right? And the total number of nephron that is present in a single kidney is 1 million. So 1 million nephron per kidney. But obviously there will be a range because 1 million is the average number. So the range that is given in book is 0.8 to 1.2 million nephron per kidney, right? Along with that, you also remember that the length of a single nephron is 5 centimeter. Again, the range that is given in book is 45 millimeter to 65 millimeter. This is the length of a single nephron, right? Now, remember that the regeneration of the nephron is not possible, although hypertrophy is possible. So, it is seen that along with aging, the number of nephron reduces inside the kidney. The data that is given in books and articles is that after 40 years, there will be decrease in 10% of nephron per year, right? So after 40 years of age, there will be gradual decrease in nephron, and how much? 10% reduction in the nephron number per year. With this calculation, it has been seen that at 80 years of age, there will be only 40% of the total nephron remaining in the kidney. But even with this 40% nephron, there will be no problem in function of the kidney because of the hypertrophy of the remaining nephron. But clinical problem, like for example, chronic kidney diseases will arise whenever the total number of nephron is reduced to 70 to 75% of the original. Means only 20 to 25% nephrons are remaining. Then the clinical problem will be arise, that is nothing but chronic kidney disease. So this small information you have to remember for your MCQ. Now the next information that you have to remember is that total blood flow, okay, in both the kidney. This has been asked in MCQ. Your answer will be, it is 1000 ml to 1260 ml per minute. This is the total amount of blood flow in both the kidney, and this amount is 20 to 25% of your total cardiac output. This has been asked in MCQ. That if your cardiac output is 5 liter, 20 to 25% of the cardiac output will diverted through the kidney. This is the total amount of blood flow in kidney. Now, within this total amount of blood flow, you know that the maximum blood flow is going through the level of cortex of the kidney. So, cortex is receiving the maximum blood flow, 90% of the total blood flow, and medulla is receiving only 10% of the total blood flow. That means we can easily understand that medulla is more prone to ischemic damage. Okay, the better answer is the corticomedullary junction. That is the area which is more prone to ischemic attack, right? So the blood flow, you know. Now apart from blood flow, you know, you also have to remember separately about plasma flow, because in kidney we are more interested in plasma flow rather than blood flow, because the filtration, which is the basic function of the kidney, the filtration occurs from only the plasma, not the cell, right? So that's why the total amount of plasma flow, that is known as the renal plasma flow, or PF, the normal value is 625 to 700 ml per minute. So this is the total amount of plasma flow in both the kidney. So after this information, now we are going to discuss different types of nephron that is present in our kidney, right? So you know that according to the location of the nephron, that where the nephron is located, there are two subdivisions, two different types of nephrons are present in the kidney. So you first look at this diagram. So suppose I am taking a cross section of the kidney, okay? So under this cross section, you are finding out a diagram like this, okay? So this is the cortex of the kidney, right? And this is the medullary portion of the kidney. Medulla of the kidney. I have taken a cross section. Now again I am dividing this medullary portion into two parts, that is outer medullary region. So this is my outer medullary region, and obviously this is the inner medullary region, inner medullary segment or inner medullary region, right? Now if you look at the nephron, some of the nephrons, they are dominantly located within the cortical area of the kidney. So suppose this is the Bowman's capsule of the nephron, then this is the proximal tubules, and then this is the loop of Henle, right? And then this loop of Henle is draining at the level of collecting duct. So this is collecting duct, right? So this is one type of nephron. I can understand that this nephron is dominantly present within the cortex, although some part is entering within the medulla, but it is only the outer medullary portion of the medulla, not the inner medullary portion. But if you look at the other type of nephron, so look at this other type of nephron. So this is the Bowman's capsule and glomerulus, proximal convoluted tubules, and now this loop of Henle is very long. It is entering deep inside the medulla, and then again it is forming the DCT and draining at the level of collecting duct. So now if you look at this red color nephron that I have made here, this nephron is very long and it is entering in the deep medulla or the inner medullary region. But this yellow color nephron, that is a shorter one, and this is never entering into the inner medullary portion. So this yellow color nephron, this is known as the cortical type of nephron, and this red color nephron that I have made here, this is known as juxtamedullary nephron. This is known as juxtamedullary nephron, right? But if you note down this diagram, you will be finding out that the glomerulus of both type of nephron, whether it is cortical or juxtamedullary, the glomerulus is always present within the cortex of the kidney. This information you must have to remember because it has been asked in AIIMS entrance examination. So glomerulus is always present at the level of cortex of the kidney. The loop of Henle of both the nephron can enter inside the medulla, but cortical nephron means it will never enter inside the deep medulla, but juxtamedullary nephron means it will enter deep inside the medulla. Now if you look at the numbers of these two types of nephron, cortical nephrons are the major one. 85% of the total nephron in the kidney is the cortical nephron, and 15% of the total nephron is juxtamedullary nephron. Now obviously the question will arise that why you require two types of nephron, right? So if I ask you what is the main function of the kidney, all of you will know, all of you will say that it is excretion of the waste product from the body, and this function is mainly performed by cortical nephron. So the cortical nephron is mainly dedicated for excretion, okay, excretion of waste product. So what is the function of this juxtamedullary nephron then? You know that whenever you want to excrete something from your body, you have to excrete along with water. So water will also be excreted along with the waste product. But if you excrete huge amount of water, then there will be multiple problems. So that way, reabsorption of the water, or I can say that concentration of the urine is done by concentration of urine by reabsorbing the water is done by juxtamedullary nephron. So the cortical nephron, the main function is excretion of the waste product, and the juxtamedullary nephron, the main function is concentration of the urine. Not only that, there are many other differences between these two types of nephron. So we have to remember them for our MCQ. So the cortical type of nephron and juxtamedullary type of nephron, right? So we have already seen in the diagram that the length of the loop of Henle, so I am writing here loop of Henle Henle. It is shorter in length and it is very long in case of juxtamedullary nephron. Now, if the loop of Henle is very long, what will happen? The peritubular capillary, I hope all of you know what is peritubular capillary. You know that there will be a capillary network which will be present surrounding this nephron, and that is known as a peritubular capillary like this. Similarly, there will be peritubular capillary surrounding this cortical nephron also. So, if you look at the peritubular capillary in this diagram, so obviously the cortical nephron means peritubular capillary loop will be shorter in length. So, I am writing here that cortical nephron means peritubular capillary loop. It will be also shorter in length and it will be very long in case of juxtamedullary nephron. This long peritubular capillary loop in case of juxtamedullary nephron is also known as vasa recta. Very important information for your MCQ. So the peritubular capillary loop which is present surrounding the juxtamedullary nephron, they are very long and entering deep inside the medulla. That peritubular capillary, that is the blood vessels, is known as the vasa recta, right? So this vasa recta has some important functions. Could you recall that? This vasa recta is responsible for counter current exchanger mechanism. Counter current exchanger mechanism. So when we will be discussing the counter current system in the kidney, you will understand that counter current mechanism has two parts. One is counter current multiplier and one is counter current exchanger. The counter current multiplication system, the counter current multiplication is done at the level of long loop of Henle of the juxtamedullary nephron and counter current exchange done at the level of peritubular capillary loop of juxtamedullary nephron, which is also known as vasa recta. That means you can understand from this discussion that it is the juxtamedullary nephron where this counter current system is operated, right? So this information is very crucial. You will be understanding this counter current system when we will discuss this in a separate topic, right? Now apart from this, there are many other differences. So I am writing that. So I am writing here the blood flow. You know that blood flow is high at the level of cortex. So obviously the cortical nephron will get higher amount of blood flow. The blood flow amount that is given in book is 5 ml per gram of tissue per minute. And in case of juxtamedullary nephron, this blood flow is very less, that is 0.6 ml per gram of tissue per minute, right? So cortical nephron is getting very high amount of blood flow. Not only that, if you look at the partial pressure of oxygen in the blood which is flowing at the level of cortical nephron, the partial pressure of oxygen is 50 millimeter of mercury and the partial pressure of oxygen at the level of juxtamedullary nephron is only 15 millimeter of mercury. Not only that, the cortical nephron, they are highly metabolically active nephron because they are excreting metabolites from your body, right? So that's why if you look at the oxygen consumption, of the cortical nephron, they are very high. If I ask you how much, then it is 9 ml per 100 gram of tissue per minute. This is the oxygen consumption in the cortical nephron. So I am writing here in next paragraph so that you will be understanding this better. So in case of cortical nephron, the blood flow is 9 ml per 100 gram of tissue per minute, right? And in case of juxtamedullary nephron, this is only 0.4 ml per 100 gram of tissue per minute, right? So even if you don't remember the exact value, at least you remember the ratio of blood flow between cortex and medulla, the ratio of oxygen consumption between cortex and medulla. So the ratio of blood flow is 5:0.6 and the ratio of oxygen consumption is 9:0.4. This has already been asked in PGI Chandigarh examination. So please be careful here. Now the last difference that I am going to write here is oxygen extraction ratio. Oxygen extraction ratio, right? So what is oxygen extraction ratio? You are extracting oxygen from a particular amount of supply. So if you take a ratio between oxygen consumption, okay, upon your oxygen supply, right, then this ratio is known as oxygen extraction ratio. So if you calculate this oxygen extraction ratio for this cortical nephron and for this juxtamedullary nephron, what do you think? So you must be thinking that cortical nephron means oxygen consumption is very high. Okay, so the ratio will be higher, but that's not the normal scenario. In case of cortical nephron, the oxygen consumption is very high. Supply is also very high. But if you compare this numerator and denominator, then the supply is much more higher than that of the consumption. So both are high. But if you look at the numerator and denominator of this ratio, then the denominator, that is the oxygen supply, that is much more higher than that of the oxygen consumption. So in a ratio, if the denominator is higher than that of the numerator, obviously the ratio is going to be reduced, and that's why the ratio is low in case of cortical nephron, and this is only 0.17. This ratio is high in case of juxtamedullary nephron. The ratio is 0.83. So getting my point. In case of juxtamedullary nephron, consumption is lower and supply is also lower. But supply is very lower than that of the consumption also. That's why the ratio is higher in case of juxtamedullary nephron and the ratio is lower in case of cortical nephron. So now you are understanding that if you look at the difference between this cortical and juxtamedullary nephron, cortical nephron means blood flow is also high, partial pressure of oxygen is also high, oxygen consumption is also high. But if you look at the oxygen extraction ratio, this is lower in case of cortical nephron than that of the juxtamedullary nephron. So this way you have to remember this because it has been asked in MCQ. Right. Now after discussion of these two different types of nephron, next part is very simple. All of you know that is the basic structural part of a single nephron. What are the different parts of a single nephron? I am 100% sure that all of you know this thing, but again, for our understanding purpose, I am going to discuss this in a quick version. So this is Bowman's capsule. Then you know that there will be a proximal convoluted tubules and there will be a straight portion. So now look at the diagram. What I have made here, this is nothing but the Bowman's capsule. So inside this Bowman's capsule, there will be glomerular capillary is here, right? And then you know that the proximal tubules will arise. Now here in this diagram, you are finding out that proximal tubules means it has two parts. That is proximal convoluted tubules PCT and proximal straight tubules PST. So there will be convolution in the first part. So that's why this is known as the proximal convoluted tubules. And there is no such convolution on the second part of the proximal tubule. That's why this is known as the proximal straight tubule. Getting my point? So proximal tubule means it has two parts. One is proximal convoluted tubules and proximal straight tubules. Now, if you look at the ultrastructure of these proximal tubules, ultrastructure under electron microscope, then there are three different segments within this same proximal tubule. So what I am saying, although we are classifying the proximal convoluted tubules and proximal straight tubule depending on the gross structure, if you look at the ultrastructure of the epithelium cells of this proximal tubule, there will be three subdivisions, and that subdivision are known as S1, S2 and S3 segment of the proximal tubule. So S1 is nothing but the first portion of the PCT, right? S2 is the middle part, that is the some portion of the proximal convoluted tubules will be there and some portion of the proximal straight tubule will also be there. So S2 segment means PCT, the later half, plus first part of the PST. and the last portion of the PST is known as the S3. So this portion, the last portion of the PST, this portion is nothing but the S3. So ultrastructurally, if you look at the proximal table, then there are three subdivisions, S1, S2, S3. But grossly, it has two subdivisions, proximal convoluted tubules and proximal straight tubules. Along with that, you have to remember that this S3 portion of the nephron, this portion is generally located at the corticomedullary junction, and this is the segment which is most prone to ischemic attack. Okay, so this is the segment which is most prone to ischemic attack, right? So whenever there is ischemic damage of the kidney, this is the part of the nephron which is going to be damaged at the earliest, that is the S3 segment. Now after this proximal tubule, all of you know that there will be loop of Henle. So the next portion is the loop of Henle. So I am drawing here the loop of Henle. Now this loop of Henle, obviously all of you know that there is a descending portion, right? This descending portion is always thin in nature. That's why this is known as the DTS, that is descending thin segment of loop of Henle. So this is a thin portion. Now the ascending portion of the loop of Henle has two parts. The first portion of the ascending portion of the loop of Henle is thin in nature, and this is known as ATS. This is the universal short form that is used for description of this different part. ATS, ascending thin segment of the loop of Henle. And the remaining portion of the loop of Henle is the thick one. So this portion of the loop of Henle, this is thick one. This is known as TAL. That is the thick ascending limb of loop of Henle. So look at, so whenever you are using the short form TAL, when T is appearing at the first, that indicate thick ascending limb of loop of Henle, right? Along with this, you remember that this ascending thin segment of the loop of Henle, this portion is only present in case of juxtamedullary type of nephron. It is not present in cortical nephron. So I am writing here, this is only present at the level of juxtamedullary type of nephron. It is not present in cortical nephron. So the cortical nephron means I can understand there will be only one descending portion and only one ascending portion. The descending portion is always thin and the ascending portion is all thick, right? So this is about the loop of Henle. Then after the loop of Henle, we all know that the distal tubule will start. The distal tubule means again there will be a convoluted portion, and the last portion, the convolution is a little lesser. That's why we say that this is DCT, that is the distal convoluted tubules, and the last portion of this distal tubule is known as CT, that is the connecting tubules. It is connecting the nephron along with collecting duct. So this is the collecting duct. So this is the collecting duct, right? So this is known as connecting tubules. So combination of these DCT and connecting tubules, this is nothing but distal tubules of nephron, right? Now this connecting tubules has an important functions. This is the only part of the nephron which is going to be secreting kallikrein. So all of you know that this kallikrein is present in your plasma also. So this connecting tubule is the only portion of the nephron which is going to be secrete, the renal kallikrein, right? So this information can be asked in MCQ, so that way you should remember. Now this collecting duct, okay, this collecting duct, whether it is located inside the cortex or medulla. Suppose this is the above portion is the cortex and this portion is the medulla. So the collecting duct has two parts. The portion which is present within the cortex is known as the cortical collecting duct, and the portion which is present within the medulla is known as the medullary collecting duct. Each of this portion has important functions, okay, that we are going to discuss gradually. But for the time being, you remember that the collecting duct, okay, contain two types of cell. Epithelium cell. You have to remember the name. Epithelium cell is present in everywhere, the proximal tubule, the loop of Henle, the collecting duct also. But at the level of collecting duct, the epithelium cell has some name. Okay, what are they? One is known as the P cell and another one is known as the I cell. So P stands for principal cell of collecting duct, and I cell, I stands for intercalated cell of kidney, right? So this principal cell or the P cell, it has three important functions, very important for MCQ. This is the cell which is going to absorb sodium at the level of collecting duct. Okay, so later on we will discuss the function of this cell in detail during sodium reabsorption, right? But for the time being, you remember that collecting duct cell, that is the principal cell, it is responsible for sodium reabsorption. Not only that, it is also responsible for potassium secretion, and it is also responsible for water reabsorption at the level of collecting duct, right? Absorption or reabsorption. Now this intercalated cell, it has two subtypes, alpha intercalated cell and the beta variety of intercalated cell. Alpha intercalated cell, this is responsible for secretion of acid, H plus ion secretion. So please remember, this I cell is the cell which is secreting H plus ion in your urine at the level of cortical collecting duct and medullary collecting duct, and this cell is responsible for acidification of your urine. So this is a very famous MCQ. So acidification of your urine is done in which portion of the nephron? That is the collecting duct. We will be discussing this later on also, but for the time being, remember this alpha variety of intercalated cell. This is the cell which is responsible for acidification of your urine. So what about the beta intercalated cell? Beta intercalated cell is responsible for bicarbonate secretion at the level of collecting duct. So this way, remember that the collecting duct contain two main types of cell, principal cells and intercalated cell. The major population is the principal cell. Right. Now, after discussing the different parts of the nephron, now the last thing that we have to remember, that what is the difference between proximal convoluted tubular cell and the collecting duct epithelium cell. Structurally and functionally, they are very different. So, what is the difference between PCT or the proximal tubular cell and the collecting duct cell? Anatomical as well as functional difference. So, I am drawing a cell of proximal convoluted tubules. Look at the diagram. So, this is one single epithelium cell of the proximal convoluted tubules, right? As you can find out here, there are multiple microvilli present at the luminal border of the proximal convoluted tubule. So this is the luminal side. This is towards the lumen, right? There are multiple microvilli. This is known as brush border. So proximal convoluted tubules means there is presence of brush border. Okay, this brush border is not present at the level of collecting duct epithelium cell. So if I draw a collecting duct epithelium cell, this kind of microvilli will not be present, so no brush border. So again, suppose this is your luminal side, right? Now the second thing, I am drawing another cell just close to this. So this is another epithelium cell here. Similarly, I am also drawing another epithelium cell at the level of collecting duct, right? Now, the apical most portion of these two epithelium cell will be connected with one another with the help of a tight junction. So this is the attachment point between two epithelium cell, which is known as the tight junction. This has been discussed in general physiology, tight junction. So tight junction will be present at the level of collecting duct epithelium cell also and in between the proximal tubular cell also. But the proximal tubular cell means the tight junction is leaky in nature. So I am writing here, the leaky tight junction is present at the level of proximal tubular cell. But if you look at the tight junction at the level of collecting duct, then this is tight junction. So tight junction means the tight junction is so tight that no molecule will be able to pass through it. But if you look at the proximal tubular cell, this is leaky. Leaky means through this tight junction, certain molecule, small molecule can pass through, and this molecule will easily pass through in between two cells and it will enter in the blood. That means this is the kind of reabsorptions from the lumen. Which molecule? Small molecule, like for water, sodium, potassium, all these small molecule. They can easily penetrate through this leaky tight junction and they can easily reabsorb in your blood. Okay, and this kind of reabsorption is occurring in between two cells. It is not occurring through the cell. This kind of transport or reabsorption is known as paracellular type of transport. This kind of reabsorption is known as paracellular kind of transport. But if you look at the collecting duct epithelium cell, the tight junction is so tight that this kind of paracellular transport is not possible. So that is the third difference between these two, that paracellular transport is possible, paracellular transport is possible, okay. But in case of collecting duct, the paracellular transport is not possible, right. So how the substances, like for example sodium, potassium, that will be absorbed at the level of collecting duct cell, paracellular transport is blocked. So obviously the substance has to pass through the cell membrane with the help of certain carrier protein or transporter protein, and again these substances will pass through this basolateral membrane with the help of certain channels or carrier protein. This kind of transport, which is occurring through and through the cell membrane, is known as the transcellular type of transport. So is this transcellular transport is possible at the level of proximal tubule? Answer is why not? There will be increase in surface area because of this microvilli, and that will contain huge number of transporter. With this transporter, this transcellular transport is also possible at the level of proximal tubule. So I am writing here point number 4, that is the transcellular type of transport is present in both the area. So transcellular transport is present in both the area. Okay. Now the last difference between these two, the microvilli of the proximal tubular epithelium cell contain one enzyme, and that enzyme is known as carbonic anhydrase enzyme. So I am writing here Ca, carbonic anhydrase enzyme type 4. So please remember this enzyme which is present on the microvilli membrane. This is specific for microvilli membrane, and this is which variety? Carbonic anhydrase type 4. Because the microvilli is not present at the level of collecting duct, this carbonic anhydrase type 4 is not present in collecting duct cells. So I am writing here the fifth difference. Ca type 4 is present in proximal tubular cell, but this Ca type 4 is absent in case of collecting duct epithelium cell. So apart from this Ca type 4, obviously there will be other variety of carbonic anhydrase. The cytoplasmic carbonic anhydrase is the Ca type 2 variety. So this Ca type 2 variety is present almost all cells but inside the cytoplasm. So obviously it will be also present at the level of the collecting duct epithelium cell also, and it will be also present at the level of proximal tubular epithelium cell also. So carbonic anhydrase type 2, it is present in both the location, right? So obviously you are thinking that you are talking about carbonic anhydrase type 4, carbonic anhydrase type 2. What about the type 1 and type 3? There are multiple subvariety of carbonic anhydrase, but for the MCQ purpose, I have to remember that this carbonic anhydrase subtype 1 is present on RBC membrane, right? Type 2, I told you that this is present in almost every cell and it is present at the level of cytoplasm, right? Type 3, it is mainly the carbonic anhydrase of muscles. It is the carbonic anhydrase of muscles. And type 4, just we have discussed that this is the carbonic anhydrase of brush border or microvilli. So obviously it is present at the level of kidney, proximal tubular epithelium cell, as well as it is also present at the level of GIT. So this small information you may remember for your MCQ purpose. Now We have discussed the various difference between this proximal tubular cell and the distal tubular cell. Right. Now, carbonic anhydrase enzyme we have also discussed. You know that there is one drug which is the blocker of this carbonic anhydrase enzyme. Could you recall that? All of you will be easily recalling that. That is nothing but acetazolamide. So now if I ask you, acetazolamide blocks which subtype of carbonic anhydrase? Type 1, type 2, type 3, type 4. Okay, so your answer will be at the level of nephron, it blocks, okay, both the carbonic anhydrase type 4 as well as carbonic anhydrase type 2. Please remember both the variety type 4 and type 2. So at the level of proximal tubule, it is blocking this also and the membrane also. But at the level of collecting duct, it is blocking only the cytoplasmic variety of carbonic anhydrase. That's why the question is, the acetazolamide, the dominant action is on which part of the nephron? Obviously, the dominant action is on proximal convoluted tubules, but the secondary action is present at the level of collecting duct. So this is all about the functional anatomy of kidney.